What's up, folks? Good afternoon. Everyone's got their snacks. Amy, is that a Magic Bullet cup?
Yes, I was taking my vitamins.
I have one of those too. That's why I recognized it. Magic Bullet. I use it all the time, so it's great.
I hadn't realized that I had my black shirt on until I was like, why am I wearing pink? But I fixed it.
I thought you were just advertising for Buc-ee's. I'm just looking at all your backgrounds to pass the time here. Aurora's got this like really epic TV setup behind her with a sound bar and multiple stuff going on there.
It's my husband set up for whenever he plays video games or watches anime.
As a fellow gamer, I understand. Sun looks like he's in a black hole right now. He's been sucked into another dimension down there. And Jaleisha just makes me feel inspired. I can't figure out why. Is that like subliminal messaging to help you feel more inspired?
I mean, I guess it can be taken that way. Just don't look too closely at the surrounding things because we've got a monkey, your skulls, and then the line of snakes.
I'm hoping to have a different background soon if we ever get moved to this new house. If they quit delaying my closing date. Hoping it's going to happen this week finally. You've ever closed on a house? It's so stressful, or it's always constantly changing. It's aggravating, frustrating, to say the least. But hopefully it's the last week. I'm tired of dealing with it. All right. So, I guess you all want to know who won the project from Friday. Yes? No? No one cares? Okay, we'll move on to lecture. Let's go. Actually, before that, just to keep you in suspense just a little bit longer, I do want a clinic story or two, because you guys did go to clinic on Thursday. I didn't really have much time to hear anything on Friday. But I know a few of you have done some competencies, and I would like to hear all about it. Maybe you can give your classmates some encouragement of how it went, or how it didn't go, or some recommendations, some advice. Anybody? I know a few of you have asked me about image reviews, so don't make me call on you. Give some wisdom. A lot of people haven't comped yet. All right. John, you just look like you're dying to say something. Let's impart some wisdom on competency since you've done yours.
I don't know, just do it.
Just do it.
I mean, I don't think mine is perfect. I mean, I know the problems already, I think, with mine. But, you know, I looked at where I'm going to be for the next 2 weeks. I talked to the tech, like, hey, do you think I'm going to be able to get this competency in this where I'm going next week? He was like, I don't know, maybe. But you also don't know, like, who your tech is going to be, I could be really easy, and they could be really, more difficult or something like that. Just out of curiosity, I mean, if we give it our competency a shot, and I don't know, it needs improvement or something. Can we have another chance at it, or no? Is it just one shot? That's it.
One shot, you're done. You're out of the program. No. You'll always get another chance. Yeah, if you screw up the first time, you get to do it again. Don't worry about that.
I mean, I'm just like, what is like? I know mine is a little bit rotated, and I think my marker is backwards.
Mm-hmm.
So, and then she also said something about. I mean, I shielded. I don't think you can see it on the comp. Like, I guess it was too low.
That's pretty typical for a chest, though. Most chests, you're not going to see a shield, so that's okay.
She mentioned, she's like, I think the shield. She's like, I think they might not like that shield isn't visible on the X-ray.
It depends on who you talk to, but
I made sure to choose my favorite professor to look at my image.
I sense some brown nosing going on here. It's all over your face. All over your face.
So, I mean, those are, I think, the big issues with my competency. But I knew that after I got it. I looked at it, and then I was like, okay, submit it or not. And my tech was just like, I don't know, it's up to you.
So do you feel going forward, John, you feel like more confident going forward with the comps now that you got that first one out of the way?
Yeah, I mean, to me, the chest and the lateral, like the PA and the lateral, I mean, we've had the most exposure to them overall, so it's been burned into our brains the most.
I hope so.
And I mean, I think I've done maybe 4 or 5 altogether.
Mm-hmm.
So when you're in the moment doing it, I mean, obviously when you step back and you're not in the moment, you can remember all the steps and every little teeny tiny thing you need to do. When you're in the moment, it's like, you kind of choke up and you do little things. So yes, I do think going forward.
Very good. Very good. Okay, I'm going to pick on somebody else here. Maricela, I know you got a KUB. Why don't you tell us about that real quick?
Well, I don't know. I guess it's very different as to when we were practicing in lab. But I think my image was okay. It's just the iliac crest was a little bit cut off, one of them. But the tech did tell me that everything, all the criteria was in there. And she did give me a couple of tips for the next time. But I think I did pretty good.
Very nice. And how do you feel moving forward now that you got that first one out of the way? Does it feel like you feel better moving forward, or you feel more nervous?
I feel better. I honestly think that I'm more prepared, like for next time that there is a KUB. I feel like I will be able to take the initiative into doing it. So, yeah. But the techs were really, really helpful. I feel like I learned a lot from them.
Very good. Very good. So definitely, guys, I mean, don't keep waiting around if you have not attempted yet for a competency, because we're already at the end of September, and you're really going to be amazed how fast this semester is going to blaze by, especially being in the holiday season. I don't know about you guys, but whenever it's the holiday season, I feel like time's non-existent. Like all of a sudden you're at Christmas and the year's over. It's really going to feel that way. So definitely start jumping in there. Get that chest and abdomen done. That is your requirements. Remember, a chest and an abdomen by the end of the semester. Get those as fast as possible, especially if one of your later rotations is like surgery or IR or something. You definitely don't want to wait till then, because you're not going to have that opportunity to jump in there and get that competency. And the last thing you want is to be having to go during makeup week, extra time in clinic. I don't know about you. I wouldn't want to do extra time in clinic on makeup week. So that could be a week off for you to stay for finals instead of having to catch up on your comps. Definitely keep your mind focused on the time scale.
Mr. Donovan, I thought we only had to do the chest, the PA, and the lateral. Do we have to have the abdomen comped as well?
Were you told differently? I was told chest and abdomen. But
That the Mr. Fung gave, but they did encourage the KUB as well.
so wait, you're saying what'd you say, Isabel? You were cutting out.
So it's just chest.
It is just chest.
They encourage you to do abdomen to do it, but it's just chest.
Okay, well in that case, I'm still going to say get your chest and abdomen. Do it, because you want stuff to roll over anyway. I mean, especially after this week, guys, you're going to be clear on upper extremities. That opens up a whole lot more comps you can get. So get those fingers, get those hands, get those wrists, forearm, elbows. Those come in quite frequently. So sorry if I misspoke there. It's actually even used to during this part of the semester, you guys would need 8 by the end of the semester. So my numbers are all screwed up. Normally it's 8 that you need. So if it's just 1, that's even easier to acquire. But regardless, try to get as much as you can. I promise you, moving into the next semester, you're going to feel so much better and a lot more stress-free if you don't have that huge amount to acquire all at the same time. So let's say, for example, I don't know how the numbers are going to change because we keep changing the numbers due to the COVID situation. Let's say you do need 8 next semester. If you get 8 this semester, you don't even have to worry about getting 8 next semester. You know you should keep going, but that's one less thing to worry about. So always push yourself to get as many as possible because they do roll over numbers-wise. So definitely think about that. All right. So.
I have a quick question, Mr. Donahue.
Oh, yeah, sure.
Sorry.
Go ahead.
So once we did, I know I copped and I did my image review with Mr. Fung today. The lead grade, we're done with the image review part. What's next?
So you did the image review, you said, yes, with Mr. Fung? So you're done then. He's just going to go in there and verify the image review and the competency put in by the tech, and that it's done. It's on your record. So you don't have to do anything else at that point.
Okay. Okay, thank you.
Get more competencies. That's the only thing I'm going to tell you to keep doing. Go crazy. Also, guys, make sure, since we've already finished our first rotation, make sure you're still putting your logs in, your daily logs. I'm sure everyone's been on top of that. I'm looking for someone to look away from the screen right now.
About the daily logs, I can't see mine when I'm at home. I only see my logs and can only access them when I'm at a clinic site.
You go to your daily log activity. On the side, it gives you reports, and then it gives you a link to do the daily logs, and it shows you all of them.
So you don't just click the daily logs like you'd regularly do when you're at the site? Because that's what I go. Because I go to the site and I click daily logs, but it doesn't let me do anything unless I'm at my clinic site. It won't even show it to me.
Oh, for me, it does. You need to go to the report section, and then under it does show you the daily logs activities. It shows you from the first one that you put in to the latest one.
Okay, I'll try that.
And make sure you select the right date too, because every day the calendar changes.
Oh yeah, I noticed that.
We got that figured out.
We'll see.
Also, guys, make sure you put your tech evals in. When you finish your rotation, you have to do a tech eval. That's something you don't want to forget either. That's part of your grade. Putting tech evals for each rotation. So you should all have one tech eval in trajexis. They're due at the end of the semester, but I would do it now so you don't forget. Y'all know what I'm talking about? Tech evals? Okay, so there is an option within trajexis where you can put a tech evaluation in. You're going to find the technologist's name that you were with the most during that rotation, and you're going to evaluate how it was working with them. And be honest, it's completely anonymous. Your name won't be on it, and they don't even get it till way later, so they won't know, oh, that was the person that was just with me. They totally don't know. We want you guys to be honest for feedback. That way we can communicate to techs that aren't doing what they're supposed to be doing. But yeah, go into
Located, Mr. Donahue?
Say again?
Where in the trajexis is that located in?
I would have to look at one of your students because my trajexis is laid out differently than you guys, but there should be an option for a tech eval in trajexis. And you'll put their name in there and actually give them do like a little survey on them.
I believe it's under evaluation.
Under evaluation. And take a look and let me know, let everybody know if you're logged into that. I'll get started here in a second.
It'll say evaluation, and then it'll say like clinical instructor evaluation. That's what it is.
Yeah, that's it. That's it. All right, guys, let's go ahead and get started back. Oh, I'm sorry, I got to announce the winner. I'm sorry, I keep forgetting. So the winner for the project on Friday was Duyan. Duyan won. Good job. For accuracy of the shapes of the anatomy and also for accuracy of labeling. So very well done. You will get 2 bonus points on your lecture exam next week. Good job. Good job. And we'll be doing this activity again, so there'll be more opportunities to win some points. All right. Just make sure you go buy some Play-Doh this time. Those of you that didn't have Play-Doh, have it on standby. All right, let's get back into lecture. Okay, so we left off talking about the fingers. And by the way, correction before I start here, guys. I remember there was a discrepancy on the lateral fingers. So I did go back and look on Bontrager and talk to Mr. Fong as well. So it is pinky side down for the middle finger as well. Remember we had a discrepancy on that last week? You're going to have the pinky side down when you're doing that lateral middle finger, lateral third digit. I know I'd said thumb side down. You're actually going to do pinky side down. So I was teaching the Merrill's way. We're going by Bontrager because that's your book. Go by the Bontrager method, pinky side down. The only one that's going to be thumb side down would be the second digit, that lateral finger. All right. Okay, guys, so positioning of the hand and wrist. Our main routine projections for a hand and a wrist, by the way, are going to be the PA oblique, and the lateral. Now, you will notice right away there's no APs there. That's because we do not do APs on a hand and wrist, period. You will never do an AP hand or wrist. You will see one instance of that when we move forward here in the PowerPoint, but even then, you're just not going to do an AP hand or wrist. Even though we're going to show you one alternative method, do not ever do an AP hand or wrist. It is not accepted by the doctors. It is not accepted by the radiologist. It is an obsolete exam, and the preferred method is always going to be a PA oblique, and lateral. Typical routine. Hang on. Someone's talking on the mic here. We'll mute you. There we go. All right. Now, there are some special views we're going to go over as well when we're talking about the hand and wrists. That's going to be what we call the lateral hand in extension, a wrist with ulnar deviation, and then the modified Stecher method. We'll go over these specifically as well. The only one of those that you learn in lab would be the wrist with ulnar deviation. And of course, you did learn the PA, the oblique, and the lateral for hand and wrists. We do got to know these other special views as well. So let's go ahead and start with the PA hand. Simple, typical view. Our central ray is going to always enter right at the third MCP joint. Remember that stands for metacarpophalangeal joint. CR right at the third MCP joint. One thing of importance to remember is you want that hand completely flat on that IR. On that IR. And by the way, guys, I did get a text from a couple of you on this question here. You were asking me for some of these extremities where the little line needs to go on the cassette. It needs to go towards the forearm or towards the head, which you see right here in this picture. See the little strip? You always want it to be pointed towards the head on the extremity work. You see right here. Hang on. Trying to get my annotation out here. You want that green strip to be right there, guys, for your extremity work. Facing towards you. That's going to orient the cassette correctly whenever we run that cassette. If the strip was up here, that extremity would come up upside down on the computer screen. So make sure that strip is down here. It's very important to make sure it comes up correctly. If it does come up upside down, like let's say you did an x-ray and you forgot to turn it, we can always manipulate that on the computer screen. But as a rule, we do want that strip to be pointed downward towards us to make sure when we run it, it's going to expedite the process. It's going to come out right side up and not be upside down.
Is that for all the upper extremities?
That's for the upper extremities, yes.
In lab, I don't know. Mr. Fung said anything on the forearm and below, the green strip was supposed to be on top, I think.
So he's saying the hand strip's supposed to be on top?
Yes.
I'll have to check with him because it is actually supposed to be on the bottom. Otherwise, it's going to be upside down when we run it. And like I said, in the grand scheme of things, honestly, mute, please. In the grand scheme of things, because we are dealing with digital X-rays and CR, computerized, even if it came up upside down, we can flip it. But if we want to talk about expediting the process, you want that green strip down. Otherwise, the image is going to be coming out upside down. So I'll make sure he's aware of that as well, guys. I'm going to tell him right after class. That way, if you do it in lab, you won't lose points on that. But I'll make sure I can confirm that with him at the end of class. So Amy's saying he only said for the elbow, for the green strip to be up.
I took pictures.
Different things.
Yeah, a green strip up towards the fingers it's above the elbow.
Okay, so
below the elbow, then it's flipped around.
I'll send him an email after class to make sure he's aware of that. It is supposed to be pointed towards you. Otherwise, it's going to come up upside down.
You go over marker placement too, because I think he said it's on the lateral side, and on this projection, I don't think it's on the lateral side.
It is lateral side. Well, not.
I thought we were going based on anatomic position.
Not anatomic position. But if we're looking like the hand of PA, that would look lateral. I can see where the confusion would be there. Basically, pinky side. Pinky side's where the marker needs to be. Although, once again, if you put your marker right here, guys, you're not going to lose points for that. It's just preferred on the pinky side over here, technically. And me personally, I even put mine up here. I don't put mine down here.
Are there set rules for how the marker is supposed to be? Because that's
only
even last semester, that was a big source of confusion. I never knew exactly where the marker was supposed to be.
Sure, only on laterals. Only on laterals. I'll show you when we get to the lateral hands. Technically speaking, guys, this marker can go on any of these corners for this hand X-ray. That's considered okay. But when we talk about a lateral, it is going to change. I'll show you what we talk about when we get to the lateral, okay? But technically speaking, you should not lose points if that marker is in any of these vicinities. If you do, let me know. That should not be happening.
Another question about how it's supposed to be faced. To me, that marker is AP, right, in that image. I mean, the way that Dr. Fung showed us, or not Dr., Mr. Fung.
He put it up the other way so it wouldn't be backwards?
Put it the other way, yeah. I took pictures of all the positions, and in the position for the PA hand, the marker is face down.
So, once again, it depends on where you go. Some facilities, that's a big deal, where they want it to be right side up. They don't want it to be backwards. Other facilities, it's not a big deal. Where I worked, it didn't matter if it was backwards or straight. It was fine. But that's a little minor nitpick. You should not lose points for putting that marker upside down or right side up, unless he directly said he's going to take points off for that. Did he say he's going to take points off for that?
I think he said he's going to take points off. But,
it's more a quality assurance thing, just to make sure it doesn't look backwards. But you should not lose points on that. But be aware, if you turn it the other way, it won't look backwards on the radiograph. The way it looks right there, it would actually come up backwards. But I will let them know about the green strip, guys. Don't panic about that. That should be towards the forearm. Yes.
Mr. Donahue, I texted Mr. Fong on Sunday, and when I asked him about, he said for the forearm, the long axis should match the long axis of the forearm with the green strip towards the fingers. For the elbow, the green strip should be towards the humerus.
Elbow, yes. That's not right for the forearm, though. No.
That's what he told me. So
I'll talk to him about it. I'll talk to him about it. Okay, let's move on here. I don't want to get too behind here. We'll get the strip thing figured out. Don't worry about it. Okay, guys, so there's the evaluation criteria for a PA hand. We, of course, do want to see the entire hand and carpals demonstrated. That center of field should be right at that third MCP joint. We want zero rotation. That is very important that the hand is nice and flat on that IR. If it is not, the hand will begin to oblique itself. So make sure that hand is nice and flat. Correct exposure factors and lack of motion. And one thing I want to add in there, make sure when you do these hand x-ray, guys, make sure the fingers aren't close together. If they are, the soft tissue will begin to overlap on itself. And even on some people with really crooked, gnarled fingers, the bones will start to overlap. So make sure they're spreading those fingers out accordingly. You have nice space between them. Then we're going to get a much prettier x-ray overall. But we must have tip of the fingers, that distal phalanx, all the way to the proximal row of the carpal bones. Proximal row of the carpal bones. If you collimate really tight, it is okay to cut the radius and ulna off, but me personally, I leave a little of that radius and ulna on there to make sure I'm not cutting any of the wrist off. And John, this is an example right here. This person put that marker upside down the other way because it came out straight, as opposed to that previous picture where it would have been backwards on the x-ray. But you will see they put their marker in a different spot as well. As long as you put that marker in any of these free spots of any of these corners, that is considered acceptable for marker placement on a PA hand. Any of those four corners would be okay. Just make sure it's in the light field. Okay, so a PA oblique projection. We are still putting the CR at the third MCP joint. It does not change. We want our digits to be parallel to the IR. And that should not say that. I wrote that twice accidentally. Hang on. Don't write that down. It should just say digits parallel to IR. I apologize. So you will see there in that picture two methods for doing that oblique hand. We have, of course, the sponge method, which not all facilities have, unfortunately. But we also have where it's just flat on the IR. You guys remember how I told you to do the fingers oblique? Same method applies. If you have a patient make the OK sign with their thumb and second digit, and then place the hand flat on the IR, and then spread the second digit and first digit, don't let them touch anymore, the hand is naturally in a 45-degree oblique. That's the easiest way to do an oblique hand, as long as you put it nice and centered on that film. So OK sign with the second digit and first digit, pointer finger and thumb, lay the hand flat, spread those two fingers, and then you're in a natural 45-degree oblique. Easiest way to acquire that oblique hand. Works like a charm. Marker placement can be in any of the four corners, by the way. You are going to collimate down to that part because that evaluation criteria is going to be the same as it was for that PA hand. And there it is right there. We want that entire hand and those carpal bones completely demonstrated. That's the proximal and distal row of carpals. You will often see a little bit of the radius and the ulna demonstrated. That is fine. We want the center of the field to be right at that third MCP joint. And the primary purpose we're doing these oblique hands, primary reason is to open up all the joints. It's a view of the hand that we use to open up all the joints. And we do want adequate separation of the phalanges and the metacarpals, which is talking about right here. We don't want any of these fingers or metacarpals. We want any of the digits or metacarpals overlapping each other. Even though there's a little bit of overlapping going on here, you want them to be as spread out as possible. Otherwise, it's going to look like a lateral hand. You want that nice spread going on with those obliques. Take any of the fingers off. You want thumb all the way to pinky. Someone have a question?
Yeah, I'm wondering, the fifth in the four is supposed to be touching the IR?
Say it again, I'm sorry.
The fifth in the fours, phalanges supposed to be touching the IR?
Yes, the phalanges will be somewhat touching the IR, kind of the tips of the phalanges, because you're going to be obliques. Yeah, you shouldn't have any fingers dangling up in the air. They should all be touching the IR in that oblique position. Because you're going to have OID if you don't. Now on the lateral, it's going to change a little bit. We're going to get to that next. And just watch them for motion. Once again, that can be uncomfortable for a patient, especially if they have a fractured hand or wrist. They might be wobbly on you. These very small body parts, just the slightest amount of motion can blur those x-rays. Okay, so we have two types of laterals that we do with the hand. We have what's called a fan lateral and an extension lateral. Both are done for different reasons. So for both, whichever method we choose, we're going to put the CR at the second MCP joint. I want you to put a star by that because that's easy to mix up. If you remember, the PA and the oblique hand are at the third MCP joint, but when we do the lateral, it's going to be at the second MCP joint. And the reason for that is because the hand becomes superimposed upon itself. If we focused on that third MCP, we'd actually be missing the main area we want to visualize on that hand. So we actually put that CR on the second MCP for laterals only. Now, there is a way to do this that I find easier as well. Instead of just spreading those fingers out, if you once again have them make the OK sign, put their hand down the cassette in a lateral, and then just simply spread those fingers. The hand is going to be a natural fan lateral. So have them make the OK sign, put the hand in a lateral, spread the first and second digit, and then they're in a true fan lateral. Works great. Easiest way to do that. And we do want to make sure we have adequate separation of those fingers. If you see a finger superimposed on itself, go in there and separate the fingers a little bit. You might have to go back 2 or 3 times, depending if the patient's moving on you. If it's an elderly patient, they got arthritis, you might have to give them some assistance to keep those fingers separated. But we do want those fingers to be adequately separated on that fan lateral. Get every finger in a lateral, as well as metacarpals in a lateral, and the wrist, carpal bones, the radius, and all needs to be in a nice, true lateral. Now, you will see here this marker. This is where we talk about the marker placement changing, by the way. And I hate that Bontrager puts this in here like this because it can be very confusing. The way we expect you guys to do it in lab, because it's the way most facilities accept laterals for extremities. For a lateral extremity, you do want to put your marker on the anterior side of the body parts. In other words, it's going to be over here. Let me get my drawing tool. So you would actually not put your marker here. You'd put it over here on the anterior side for laterals. It's laterals on upper extremities as well as lower extremities. So for the PA and oblique, you can put that marker in any corner. But for laterals, you want to choose one of the anterior corners. It can be on the bottom or the top of that cassette. So don't put it right here. You want to put it on the anterior side. That's because, once again, most facilities prefer it that way. Even though your book's showing it this way, most facilities want you to put it on the anterior side. Mainly remember that for lab guys. That's not something I would ask you a question on because your book is showing that this way is correct. But for lab, make sure you're putting that marker on the anterior side on those laterals. And clinic, of course. Okay, so for your evaluation criteria, we want that entire hand and carpals demonstrated. It's the same as for the PA and the oblique. We want that center of field to be directly on that second MCP joint, and we must have those fingers equally separated. The metacarpals will become superimposed. We expect that to happen. The radius and the ulna should also be superimposed. If my radius and ulna is not superimposed on a lateral hand, that tells me that the patient's arm or wrist is obliqued. We'll say it again. If the radius and the ulna are not superimposed on a lateral hand, that tells me that the patient's forearm is obliqued and not in a true lateral. This is another one where you want to watch people for motion because even if you just hold your hand like that right now, like your hand's healthy, it's not broke, it's not hurting. Holding your hand in that position can actually be quite difficult. Your fingers will start to get shaky and tremoring. So make sure you're watching your patient, especially if they shift on you, because you're going to end up having to do repeat x-rays. So someone in this case might have to actually stand out there with them and assist them keeping those fingers separated. We can do that with tape. We can do that with sponges, different tools within the department that we have that we can use to help keep that hand isolated and those fingers adequately spread out. And this radiograph right here kind of shows what I was talking about, guys. They put that hand in the OK sign. They're making the OK sign there. but they just separated that second and first digit so they're not touching each other. When you put the patient's hand in that position and put them in a lateral, it's going to be exactly how you need it to be. Just the main thing to remember, make sure those fingers are not superimposed. In a lateral, it's going to be a separate position we're about to talk about here in a second. There's two types of laterals we talk about. So that's this one right here, guys, a lateral hand extension. Lateral hand extension is literally, I call it the karate chop because you're making a karate chop motion. Why do we do this x-ray? We only do this x-ray if they're looking for foreign bodies. This is not a substitute for a regular fan lateral. This is only done to look for foreign bodies within the hand or the fingers. Very important to remember that because some techs will get lazy and do this as a lateral hand. That is not acceptable. It should only be done to look for foreign bodies or for anterior or posterior displaced fractures. That's the only other reason we would do that. Mainly foreign bodies, though. Most of the time, if someone has like a BB in their hand, glass, whatever, they're going to do that fan lateral to see if that foreign body is either anterior or posterior on the hands. They'll know where to go in there, operate, and pull that foreign body out. But also, if they just have a really bad anterior or posterior displaced fracture, it's going to give a better visualization overall as compared to doing that typical fan lateral. But it should never be used as a substitute for a regular fan lateral. It's an alternative, but not a substitute. And once again, don't let this mess you up, guys. I don't think you guys didn't do this in lab. If you were doing this in lab, you'd want the marker to be on the anterior surface of the hand right here, not on this side. It's only for those laterals. And there's the evaluation criteria for that extension lateral hands. Same thing, guys. Entire hand and carpals demonstrated from the tip of that distal phalanx all the way to that proximal row of those carpal bones. Center of the field should be at the second MCP joint. Exposure factors, no motion, keep that hand nice and still. And go ahead and collimate in on these x-rays. That's a very thin x-ray. We don't need to leave that collimation wide open. If we do, that hand's going to become washed out. The quality is going to go way down. And we're not going to be able to get a nice visualization of all those joints, those lateral metacarpals, and those lateral carpal bones as well. So watch out for that motion. I say it a lot because people will move on you on these hand x-rays or upper extremities, period, especially if they're in pain. Make sure you're always double checking right before you hit that exposure button. Are we going to save them from getting an extra exposure if they can help it? So we're going to move on to the wrists now. So the wrist projection, we're going to do a PA wrist. Our CR should be at the mid-carpal area. You'll notice that's not an exact location. Essentially, you want the CR to be directly on the wrist. That's considered the mid-carpal area. Find your patient's wrist, you put your CR directly on it. That is mid-carpal area. As far as routine goes for wrist projection, guys, you're always going to do a PA oblique, or lateral. You will see AP in parentheses right there, but don't ever do an AP wrist. Radiologist is going to be upset at you. Ortho is going to be upset at you. They do not accept those exams anymore. Even though we're going to look at one in just a second here. Always PA oblique, and lateral. Now, let me ask you all a question. In lab, did you guys position the hand like this, or did you guys do the fists? You did the fists? Good. That's very important, even though your book's not showing that. If you do a PA wrist with a fist, what that does is it opens up the carpal bones. If you have the hand relaxed, like you see right here, it actually closes the joint space of the carpal bones. So it's actually preferred to make the hand into a fist and then relax it down for that PA projection. So make sure you make note of that. A fist is going to open up the carpal bones for a PA projection of the wrists. And there's that alternative AP wrist, guys. That's what it would look like. But don't ever do a wrist like this. That's not accepted in clinic. That's not accepted in the hospital. This is obsolete. Just do not do that projection, but do realize it does exist. I say it exists for techs that just don't know what they're doing personally, but don't do that x-ray. Don't do that x-ray. Yeah, Fong said it reduces OID. It does reduce OID as well. It'll also open up those carpal bones They'll spread them out a little bit more so they're not overlapping and superimposed. Okay, so that evaluation criteria for a PA wrist is going to, of course, show the distal radius, the distal ulna, and all of our carpal bones should be demonstrated. Once again, if you see right here, this patient right here did do the fist method. We got that nice space going on between these carpal bones. That's what we want to see. If all these carpal bones are all bunched together and overlapping each other, they most likely relax the hand flat on that IR. When we do make that fist, it's going to separate them a little more. They're all going to be a little more distinct. We'll be able to visualize them a lot more proper on those x-rays. The center field should be right on those mid-carpals. We want no rotation. That wrist should be nice and flat on that IR. Small exposure factors should be low KVP, low mass, and lack of motion. And most of the time for a wrist, patient can relax their hand quite well. They should hold pretty still for you on a wrist overall as compared to doing a hand x-ray, for example. That's going to be our PA wrist x-ray, which is a little off-centered for my taste. It should be over here a little bit more. But make sure you collimate nice and tight on these as well, guys, because remember, we're only interested in the wrist area. We don't need all the fingers on there. We don't need all the forearm on there. We only want to see the carpal bones and the metacarpals as well. Not all the metacarpals, just the proximal portion of those metacarpals. Very easy comp to get, by the way. A wrist, 3D wrists. That's a great one to jump on next week. You guys are in clinic. So for our oblique wrist, that's going to be a 45-degree oblique. We simply raise the hand halfway up to a 45-degree oblique. Our CR is still in the exact same area. That's the mid-carpal area. You'll see them using a sponge right here, but that's not required. You can just have them move their hand up naturally on that IR without a sponge, as you guys learned in lab. Now you'll notice that we're not doing the fist anymore. Did you guys learn the fist on the oblique too, or just the PA? I know some people do the fist on the oblique as well. It's not required. No fist on the oblique?
Just the PA. Okay.
Okay, good. That's what I wanted to hear. Good. So you're going to have the hand straight out for that oblique. We're not interested in getting that space anymore on those carpal bones because when we go to oblique, we're going to naturally open up the joint spaces themselves with that 45-degree oblique. We're going to see the carpal bones from a different visualization and different view in that 45-degree oblique. They're going to look a little bit like this we see on the x-ray right here. Main point of the x-ray, though, is we're looking at that distal radius on the carpals, obliques to open up the carpal bones on the side of the first digit, such as the scaphoid, trapezium, trapezoid, lunate, and capitate. The other carpal bones will be a little more superimposed. We're not as concerned about those because we do get a good visualization of those on the PA. This is going to mainly let us see that scaphoid very, very nicely. Does anyone remember why we want to see this scaphoid? You'll see it says trapezium there as well. That's important, but why would it be so important to visualize scaphoid?
The most fractured bone in the wrist.
It's the most fractured carpal bone, exactly. So they're always going to double check that scaphoid bone. That oblique's going to give us a nice, beautiful view of that scaphoid as well as that trapezium to make sure it's not fractured. Central ray should still be at the mid-carpals. And, all right, my future QA techs, because you're all going to be future QA techs, are you happy with that x-ray? Or can we fix that x-ray a little more? Would you call that really good, or could it use some improvement?
That could be fixed.
Okay, how could that be fixed, Javier?
Well, the marker could be brought in a little bit closer.
Yes. Anything else?
Have the hand in the fist. It looks like the fingers are kind of in.
So this person did the fist, which is not necessary. Good observation, but there's something else here. I want you to look at this statement right here.
Collimate.
What's it say right here? Center of field at mid-carpals. Are the mid-carpals centered on that radiograph?
Oh, it's too high. There's too much radius up there.
It's too high. And look what we have. We have a lot of forearm on there. This is a common mistake a lot of techs make. I don't want you guys making this mistake. They will center too high, and they'll get a lot of the forearm on a wrist. Remember, your carpal bones need to be directly in the center, which you will get if you put your central ray right on the patient's wrist. And make sure you close that collimation up, because we don't need all that forearm on that x-ray. If they want forearm, they'll order a forearm x-ray. You're only focus on the wrist, which is that distal radius and ulna and those carpal bones and the proximal section of those metacarpals. So be careful with that. It's a very common mistake people make on their wrist x-rays. And then we have a lateral wrist. Easiest way to do that lateral, guys, tell your patient to make a karate chop. Most people know what a karate chop is. Position their arm nice and flat on that IR, and you've got the wrist in a true lateral position. Your CR does not change with any of these three views we just talked about. All three are centered right at the midcarpal area, which is directly on the patient's wrists. Main thing is, though, make sure that hand is in that karate chop position. You're not going to do a fan lateral, so don't get that mixed up. You're not doing a fan lateral like you would for a hand. Don't do this as the same way you would for a lateral extension hand. The only difference is you're focused on the wrist instead of the actual hand and digits. And this is good also for looking for foreign bodies if they do suspect a foreign body in the wrist, but it is a typical x-ray. It's going to be ordered every single routine wrist period at PA, oblique, and lateral. For evaluation criteria, same thing, guys. We want the distal radius, distal ulna, and the carpals to be completely demonstrated. We want our CR to be directly on those mid-carpals. No rotation, and we look for rotation on a lateral wrist by making sure that the radius and the ulna are properly superimposed. It's an important thing to remember. It's not on the PowerPoint. It's something you want to write down. We look for rotation of a lateral wrist by ensuring that the radius and the ulna are superimposed upon each other. If they are not, it's telling me that that patient's wrist is oblique and not in a true lateral. So same thing, guys. Looking at that x-ray, is that good or bad? See any mistakes on that x-ray?
There's rotation. Straight.
Superimposed. We're still superimposed. I mean,
I
very.
feel like it's not straight. That's what I'm trying to say. Sorry.
Oh, you mean it's okay? The arm's not straight. You are correct about that. Yes. What else?
This one's too high.
Too high.
Way too high. Look at all that forearm there, guys. Do not do your wrist x-rays like this. It's very sloppy. It's the sloppiest way to do a wrist x-ray. It's going to make you look bad as a tech. It's going to reduce the quality. And actually, that x-ray would be a lot higher quality had they centered properly on that wrist and collimated down. You do not need all that forearm on that x-ray. What else? You guys remember what I said about the markers?
Marker needs to go on the anterior side.
On the anterior side, correct. Very good. Very good. Okay, so we're going to talk a little bit about our special projections here. There are two we can cross out because they are not considered feasible anymore in the world of x-ray. They are completely obsolete. Let me get my, whoops. Oh, I'm so sorry. What did I just do? Oh, WebEx, how I love you. There we go. Hear the sarcasm dripping from my voice there, I'm sure. My love for WebEx, yes. Okay, so the two you can cross out here, guys, even in your book if you choose to, we do not do these anymore. Carpal canal and the carpal bridge. Very interesting to look at if you're just curious about it. It allows us to actually get a very interesting view of the carpal bones, but we just don't do these anymore. So we're knocking those out. We don't need to worry about those. But we do still do the ulnar deviations. Sometimes we do the Stecher method, and we sometimes will do the radial deviation as well. But we're going to focus mainly upon the ulnar deviation and the Stecher method. Why? Because they are designated scaphoid projections. And once again, if you remember, scaphoid is the most fractured carpal bone of all 8 carpal bones. So we're going to dedicate 2 separate views to make sure we visualize that properly if there is a suspected fracture in the wrist of that scaphoid. So let's start with the ulnar deviation. So for the ulnar deviation, we are going to deviate our hand towards the pinky, towards the ulna. That's rotating our wrist so that the pinky is the one that's moving to the right, by the way, or to the left. Pinky side, ulnar side. That's a 15-degree angle of our wrist. The CR will be at a 10-degree angle towards the patient's body, towards the forearm. Biggest mistake I've seen in lab, guys, is people will put the CR going the other way towards the fingers. Make sure you're pointing your CR towards your patient, towards the forearm, towards the head at 10 degrees. Do not make that mistake. That is one of your lab projections. And make sure you rotate that wrist at least 15 degrees towards the pinky. It's going to isolate that scaphoid so we get a nice, beautiful view of it. Also, that angle that we're putting on the tube is also going to help elongate the scaphoid so we get a nice designated view of it as well. So there you see right there, nice, beautiful x-ray. We want that scaphoid to clearly be seen without superimposition. So it's going to completely remove it from superimposition of all the surrounding carpal bones so we get a nice designated view. And we don't want it to be foreshortened. That's why we put the angle on the tube. It stretches it out a little bit so we get a nice, designated, beautiful view of that scaphoid. You can see right here on this x-ray. Well, this tech failed to put a marker on this x-ray, which is not good. But you're still going to put your CR on the wrist, guys, on the mid-carpal area. Make sure you have that arm rotated correctly, 15 degrees. Rotate that hand 15 degrees. Put that CR at 10-degree angle towards the patient's body. Make sure you're not turning it towards the fingers. You're actually pointing it towards your patient, towards the forearm. This will be our PA ulnar deviation. Now we also will do what's called a modified Stecher method. Show what that looks like right here. The Stecher method, there are two ways to do it. There is the one with the hand elevated 20 degrees with no ulnar deviation. And there's the version with the hand elevated 20 degrees with ulnar deviation. Can be done both ways. It makes very minute differences in the way the scaphoid's visualized, but that's two ways you can do that PA scaphoid modified Stecher method. Me personally, I always opt for the ulnar deviation. It's the easiest one to remember. It's the one you guys are doing in lab. This is simply an alternative to the ulnar deviation should the tech choose not to do it that way. It's what we call the Stecher method. Essentially, the only thing we're doing differently is we're elevating the hand 20 degrees with a sponge, and we are not adding an angle to our tube. It's a perpendicular CR. But we have two ways it's done. You either do the ulnar deviation or you do not. It makes very minute differences, but that would be the Stecher method. We're going to put the angle on the hand to stretch out that scaphoid and also isolate it by itself so we get that nice clear view of the scaphoid by itself. That's our modified Stecher method for a PA scaphoid. I don't think I've ever seen a tech do this method before. I've always seen techs do the ulnar deviation. I've always only done the ulnar deviation as well. And that's what the modified Stecher would look like. I even think the x-rays look uglier, personally. I thought that the ulnar deviation looked a lot better, actually, compared to this view. That's the way that would look on x-ray. Mainly, I just want you to remember the method for obtaining that, where you have the hand elevated 20 degrees, you have no CR angle, and you have the option of either doing an ulnar deviation or no ulnar deviation for the Stecher method. Preferred is the ulnar deviation that we learned with the 20-degree angle to 15-degree angle of tube. Okay, and then there is the radial deviation. Not done too often. Every once in a while you may see this done. It's basically just the opposite of the ulnar deviation, guys. Instead of turning the wrist towards the pinky, we're turning our wrist towards the thumb. We're deviating towards the radius as opposed to deviating towards the ulna. And what this is going to do, it's going to isolate the hamate, the pisiform, and the triquetrium specifically. Allows us to see those carpal bones on that other side instead of having that specialized view of the scaphoid with the ulnar deviation. CR will be perpendicular as well. We're not going to have an angle on this one like we did for the ulnar deviation. So for radial deviation, it's a 0-degree angle on that too. It's a perpendicular ray right at the mid-carpals. Very rarely done, only if that patient has a specified fracture of those other carpal bones. like the hamate pisiform triquetrum, that might be the reason they would order this view. But even then, they're very rarely going to order this X-ray clinic. Those carpal bones aren't fractured too often overall. Okay, so we're going to take a 5-minute break, guys, and we're going to wrap this up with the forearm and elbow projections. All right, actually, let's do a 7-minute break. 7-minute break, and we will reconvene right at 2 o'clock. We'll be back.
So I think our next meeting is next week. I'm not for sure. They use an email a few days before. When I get the email, I will text you the time and date to make sure you're available. Because obviously we're 3 hours.
right, guys, we're back. We are back. Hang in there. We're about to wrap this up for the day. Get your cams back on.
Where's she at? Felicia, what kind of drama are we doing today?
So I got some clarification, guys, on the whole cassette thing.
What is wrong with you? Your period's on?
So I found out it's Harris Health preferred.
Okay, we'll talk.
Blocker at the top.
I
for
have
hands
diarrhea.
and wrists
I've
and
been throwing
everything.
up.
So stick with Mr.
So I'm
Fong
about to
showed
pass
you
out,
that it's
and I'm
Harris
throwing
Health
up.
preferred.
So you have corona?
That is not something the
After I have
registry will
corona,
ask
all I
you
know is that
about where that
feel
green bar goes, by the way.
awful.
It's a facility
Do
by
you have
facility
corona?
preference.
Have you been exposed? Have you been wearing your mask?
So that green strip goes
It's
to
not
the
like
top.
stay right there. It's not like
Despite what the
coronavirus.
book shows, despite what I told you, because it's Harris Health preferred. So do it
Can
that
he
way
see
for
you?
lab, do that that way for
Just stop
clinic.
it. Because
Everyone
they're
got
going to end
that?
up kicking you out because they're going to
Does it always go to the top? Yeah.
Towards the
Can you get
fingers,
up and
yeah.
walk away?
All even, okay.
How long is
Wrist, hand, finger,
30 minutes.
forearm, all that. That's
Okay,
preferred
well,
by
then you
Harris
better
Health.
put something behind
Yes.
you because can he hear you?
Yes.
No.
Well, he was showing us
If
from
you
the
keep
elbow where it
acting how
goes
you're
towards
acting,
the humerus.
somebody's going to see you and they're going to be like, what's wrong with you?
Yeah, but just
When did it start? Suddenly?
Elbow, anything past that
Okay, so
goes
it's not
towards
a
the
I've
body.
been feeling
Because it'll
sick.
turn the
It
humerus
happened
away,
this
yeah.
morning. Like, okay, so
Yeah.
you haven't been feeling
Towards the
achy
humerus
or
and
sick
elbow.
or like you were coming
Before
down with something.
forearm,
So
wrist,
did you eat
hand
something
and
bad?
fingers towards the
I haven't eaten anything
fingertips.
today. Have you eaten anything that is
Yeah.
off the keto diet? No. Be
Only
honest.
one of the ones we're
Truthfully,
doing
no.
that they would have it
Anything
towards
in the
body
last
would be
couple
the
days
elbow,
that
like
are
we just
high
said.
carb
Yes.
bread,
Because it
anything
would
that
bread,
is
I had bread yesterday.
real bread,
No.
candy, real sugar, soda.
No. All right, let's get back to it, guys.
Stop it, Cinnamon! Hey! Hey! Punch you in your goddamn neck. Let's go. How do you feel now?
Bad.
Bad like what?
All right, so we're going to talk about
Like, I
the
feel
elbow and the forearm
hot.
now.
Let me see. Let's go take
So
a
for
you
our
can't read.
forearm,
I can tell him I'll
we
be
have
right
two
back.
projections.
You're telling me
So
can you go to
two
the bathroom?
projections. It's going to be the AP and lateral forearm.
That's okay. Before you
You
go,
talk
I
about
don't
the
want you in
elbow.
trouble.
It has
You just had to
three
go to the bathroom real
routine
quick?
projections. That's the AP obliques, plural, and lateral elbow. Now that's another thing that's facility per facility. Some facilities will choose one oblique over the other on elbows. Some facilities will choose both obliques. That's something that will change depending on where you're currently working. That's why it says AP obliques plural. Sometimes they want both. Sometimes they only want one. That depends on where you're actually working. But they're both considered part of the routine depending on what they choose. For example, Harris Health likes the lateral obliques. Texas Children's like the internal obliques. It all depends on where you go. Then for special projections, you have what's called a partial flexion elbow, acute flexion elbow, and a trauma lateral elbow, specifically what we call the coil method. We'll break those down as well. So let's start with our AP forearm. Main thing we are looking for an AP forearm is the epicondyles parallel to the IR. So you want to palpate the patient's elbow, feel for both those epicondyles, make sure they are parallel to the IR, make sure they're not rotated or obliqued. And you do want your central ray to be directly on the mid forearm. Midway between the wrists and the elbow would be mid forearm. Midway between the wrist and the elbow. You want that arm to be in a true AP. Can be quite difficult if some patients cannot put their arm flat, especially if the forearm is broken. So we got to use those critical thinking skills once again. Think, how could I acquire an AP forearm if the patient could not extend that arm out fully, like we see in the picture right here. That might be where you opt for doing one of those cross-table APs like we talked about in the previous class. But that's something that you have to think about, especially in those trauma situations, how to acquire that best x-ray without going for that PA, because you will notice we don't have a PA forearm listed at all on there. PA forearm does not exist. They do not want PA forearms. Now, the only reason you would ever do a PA forearm is if a patient was in a cast and it was impossible to acquire the AP. Even then, they do not want those PA forearms. You want to always go for the AP, period. And there's our evaluation criteria for that AP forearm. We want the carpals. You will notice we do want the carpals, by the way. The entire wrist. We also want the entire elbow. Carpals to distal humerus. If we have distal humerus, we have elbow. If we have carpals, we have wrists. So that's really close on that x-ray. But they do have all the carpal bones included on there. We do want the humeral epicondyles in profile, which is this area right here. We want these two We want these two condyles in profile and a true AP. And we do want slight superposition of the distal radial ulnar joint. Distal radial ulnar joint is right here, guys, at the wrist. We want that slight superposition that tells us that the hand and the forearm is in a true AP.
3 gray stays.
Low exposure factors, no
I
motion.
times I can miss.
Hold really still.
Before I gotta
And definitely
make up
collimate
anything.
in horizontally on this forearm X-ray.
None.
As you can tell, the forearm is a very thin piece of anatomy. We don't want to leave that collimation wide open. It's going to take the quality down. It's going to compensate our image. Make sure you have that nice, tight, horizontal collimation. As far as the vertical collimation, because the forearm is quite long, you pretty much afford to keep that open almost all the way. Just make sure if you do collimate vertically, you're not cutting the carpal bones off and you're not cutting the elbow off, as well as those epicondyles on the distal humerus.
There you go.
So if I had a PA forearm on there, what would you see on that X-ray? What would be different about that X-ray?
So
In
your
accordance to
biggest
the
complaint
anatomy.
is what?
Right now, the cramps in the stomach and the throwing up.
You're on mute.
Huh?
You guys remember what happens when we put the forearm in a PA?
I'm always on mute.
The radius will be superimposed
It
over
sounds like
the
a-
ulnar.
Correct. So the
I'm
proximal
trying to
portion of
think.
that race and the ulnar would be superimposed on itself, which we definitely do not want on
Unless
that
it's some eggs have gone wrong.
forearm X-ray. It's going to actually cover up some anatomy that might be important, especially a fracture. You want them to be nicely separated like you see right here, except for those
You do
joint
that for
spaces that
us,
overlap
you
just
do. You talk to
slightly.
them all the time, don't you? Don't do that.
So for a lateral
Can you actually
forearm,
see
really
me?
important points.
He's not
The
looking at me
elbow
right now,
must be flexed
but he's looking at his
90
PowerPoint. So
degrees. If it is
Don't-
not
I'm
flexed
telling
90
you,
degrees,
if
it
you
will
look
not
like
be
how you
in a
look when I'm
true
looking at you, I'm
lateral.
going to tell you
It's on the
something wrong.
elbow portion of the
You need to
forearm,
tell me
by
if
the
you have
way.
a headache or something.
The elbow
okay?
will not be in a
If
true
you have
lateral
something.
if it is not flexed at 90 degrees. We also want the wrist to be in a true lateral. The way I do that is I tell them to once again make the karate chop motion with the wrists. That ensures to me that it's going to be in a nice true lateral. I can make sure I adjust the wrist accordingly on that film. I want that CR to be, once again, right at that mid forearm, halfway between the wrists and halfway between the elbow joints. So same thing here, guys, with the laterals. This marker, as far as lab and Harris Health goes, guys, they don't want that marker there. They want it to be on the anterior surface of that forearm. So you put it over here anteriorly. So careful on that marker placement. And most of your forearms, guys, you are going to opt for a bigger cassette size because the forearm is quite long. You usually opt for a 14 by 17 on these x-rays, unless there's just a really small patient. You can use a 10 by 12, but most of the time you're going to go ahead and opt for that 14 by 17 cassette size. Longer piece of anatomy that we're visualizing, since we want the whole forearm on there, including the wrist and the elbow. And one thing to key note here, guys, whether we're talking about a lateral forearm or a lateral elbow, one of the big mistakes I see is they don't have the patient relaxed all the way down on the film. The lateral, they have their humerus elevated. If they don't have the humerus down, like have the patient like squat down and have that elbow completely flat on the IR, it's going to oblique the elbow. The epicondyles will not be superimposed. We're not going to get a good true lateral of that forearm overall. So make sure they relax that humerus down. You might have to help them push themselves down a little bit to make sure that elbow is nice and flat and they're not obliquing or pushing up their humerus and obliquing that elbow joint as well as the rest of that forearm. That's what we want to see on a nice, beautiful lateral forearm. We want the carpals and the distal humerus to be included. We do want the elbow to appear to be in a 90-degree angle of flexion. The head of the ulna should be superimposed over the radius for proper true lateral position. Head of the ulna superimposed over the radius. Ample exposure factors and no motion, of course. And this goes back to what I was talking about earlier. If that patient didn't have their humerus relaxed, like it was going up at an angle, these epicondyles would not be superimposed. It would look obliqued. And the doctors are not going to like that. They want that nice true lateral on that elbow as well as that entire forearm. And also make sure that wrist is nice and straight. Don't let them relax that wrist down. Get them to get you a good karate chop, having a true nice lateral. Otherwise, they're going to send them right back and make you repeat that x-ray. Ortho doctors are obsessed about getting nice true laterals on forearms and elbows. So whatever you can do to give them a true lateral, give them that true lateral the first time, or I guarantee you they're going to send them right back to you and make you repeat it. They have to have those true laterals to be able to diagnose properly, look for fractures, and they're just really nitpicky about it. Really nitpicky. And this is a true lateral on this x-ray. It's a great demonstration of what it should look like. But those epicondyles nicely superimposed, carpal bones nicely superimposed, distal portions of the radius and ulna superimposed. Beautiful true lateral. Collimate in horizontally once again. Forearm is a very skinny area of anatomy. We don't need to leave that collimation wide open. Collimate in is going to increase the detail, lower the dose, and give you a nice picture overall. And marker placement on that anterior side right over here. Okay, so for the elbow, once again, the routine exams for an elbow are going to be the AP, the lateral oblique, the medial oblique, and a true lateral elbow. So once again, you see the lateral and medial oblique grouped together there. Depending on where you go, once again, one facility may opt for a lateral oblique versus one facility might want a medial oblique, and then some facilities want both obliques. Either way, you're going to do at least one oblique with that elbow series. So for the AP, we want that arm to be nice and fully extended, much like we would for a forearm. We must have our epicondyles nice and parallel to the IR, so make sure you palpate those epicondyles on either side of that elbow. And your CR is going to be right at the mid-elbow joint. Make sure you find the elbow joint, put your CR directly on that elbow joint, and you're centered exactly where you need to be, as long as you're also centered nicely on that film. And there's our evaluation criteria, quite a bit for an AP elbow. Elbows are ordered a lot. They all have a lot of specific criteria that needs to be demonstrated. We do want to properly visualize the distal humerus. We must see the open elbow joint space, and we must see the proximal radius and ulna demonstrated. So once again, we do want to collimate quite tightly vertically and horizontally on this one because we're not interested in having the whole radius. We're not interested in having the whole ulna. We don't want the whole humerus on there as well. We're just interested in that area of the elbow joints. No rotation. You want those epicondyles to both be in profile like we see right there. Bilateral epicondyles in profile. We do need to see the radial head, the neck, and the tubercles to be slightly superimposed by the ulna. And then we want the olecranon process to be seated in the olecranon fossa, which will give it this appearance that we see right here. That tells us that elbow is nicely situated on that cassette. The arm is fully extended. They're not bending their elbow up. They have that nice, fully extended, flat AP elbow. Everything is exactly what it needs to be. Do make sure you collimate nice and tight vertically and horizontally on those elbows once again. It'll raise the detail overall. I find this to be quite an ugly radiograph personally. I think that's because it's a film x-ray. It doesn't look like a digital x-ray. Quite a bit of evaluation criteria just for an AP elbow. There's a lot of parts that go into it. There's a lot of mistakes that can be made for an AP elbow, mostly because people do not like to extend their arm out all the way. We tend to bend their elbow up, especially if they're injured, fractured, hurting really bad. They're not going to extend that arm out fully for you. So make sure you pay close attention to that. Once again, ortho doctors, they're obsessed with elbow x-rays. They're going to send those patients right back to you if you don't get that nice, beautiful position, whether it be AP, oblique, or lateral. Okay, and just because we need to make sure we understand this elbow anatomy, we've done this image before. Let's do a quick little review of our anatomy because there's a lot of this anatomy that's very important for the AP elbow. You can tell me what A is pointing to. What is it pointing to?
Medial epicondyle.
Medial epicondyle, correct. What would B be talking about? It's talking about this landmark area, by the way.
Capitulum.
Sure. Careful on that. That's easy to mix that up.
Is it the coronoid process?
It's not a coronoid process. We typically will not see coronoid process.
Is it the trochlea?
Trochlea, thank you. Trochlea. So the side of the ulna, guys, is where the trochlea is located. So what about C? What's C pointing to?
Trochlear notch?
Trochlear notch, very good. Trochlear, that space right there is going to be the trochlear notch. What? What about
Is that the radial head?
the radial head? Very good. What about E? Someone already said it.
Capitulum. Capitulum.
Capitulum, and F will be what?
Is that the Lateral process?
Lateral
Lateral epicondyle. Lateral epicondyle. So medial epicondyle is the one that's very protruding right here. Lateral epicondyle is directly on the other side. Watch out for that trochlea and capitulum, guys. People mix them up constantly. Just make sure you keep in mind the trochlea is always on the side of the ulna. The capitulum is always on the side of the radius. And what would H be, guys? Someone said it just a second ago.
Olecranon process?
Olecranon process. Olecranon process. And that olecranon process, guys, a little clue here on these APs. It's going to look a little bit like a square. Right here. If you got something pointing right there on those APs, that's going to be a olecranon process. It looks a little bit like a square. Easiest way to remember that. And just a couple more here, guys. Well, we already named that one. That's radial head. But what's this little protrusion here that arrow's pointing to?
The radial tuberosity.
Very good, radial tuberosity. And by the way, on this image, can you guys see the olecranon process? It's like a square right here. See that? There's that olecranon process again. And I'll make sure, so that you don't mix those up, guys, on image review. If I'm pointing to that, I'm going to put my pointer for the olecranon process on the upper edge of it right here. And if I have an arrow right here, you would tell me trochlea. This trochlea is going to be this area right here. Make sense? I'll get you some more practice images on that, don't worry. Very important that, remember on that elbow.
Could you repeat that for me, Mr. Donahue?
Sure thing. So if I'm pointing to the olecranon process on an image review, I'm going to be pointing to the upper portion right here. Ooh, I don't know why it did that. This upper area. Most commonly, I'll point right, I'm sorry, I'm making a mess with this. I can't draw with this mouse. I'm pointing to the edge, most likely for the olecranon process right here. If I point anywhere in this area, that would be trochlea. That makes sense? So my drawing is terrible with this mouse. Okay, so for the partial flexion elbows, these are two positions you guys learn in lab. Now, the only reason, biggest thing to remember for a partial flexion elbow, the only reason we would ever do a partial flexion elbow is when the elbow cannot be fully extended into a true AP. Like if that patient's arm is in so much pain or they have a really bad fracture in their elbow, they cannot extend the arm, we can opt to do this partial flexion elbow. And by the way, you will do both views. You wouldn't choose one or the other, you would do both views. So you would do what's called the humerus parallel and the forearm parallel. They're named that because that's the part that is parallel to the film. When we x-ray, the first partial flexion, we want the humerus to be nice and flat on the IR with the forearm angled upward. Versus the other view, the forearm parallel, I want the humerus elevated or upward with the forearm nice and flat on the film. It's going to give us two extended views of that elbow because we can't get that true AP. We'll be able to basically put them together to get a representation of what a true AP would look like. That patient's arm is just too fractured and too much pain. Either view, we're always going to put the CR perpendicular to the mid-elbow. The main thing is just make sure you know what part is elevated versus which part is flat on the IR for that partial flexion elbow. If you choose this in lab, you do have to do both views. Keep that in mind. So it's usually really helpful whenever you're doing the humerus parallel, you have them sitting down. They'll be able to relax that humerus a lot easier. Versus if you're doing the forearm parallel, it's easier if they're standing up. And they can lean over and put their forearm nice and parallel, flat on that IR. You'll see them utilizing the sponge there. It's not required. That's just a comfort thing, should your facility have that. And this is what the humerus parallel x-ray would look like. Easiest way to tell that's a humerus parallel partial flexion. What is very predominant? We've got a lot of humerus on that x-ray. For a humerus parallel partial flexion x-ray, we will see a lot of the humerus. Versus the other one, we would see a lot of the forearm. So obviously, the distal humerus is going to be what's best visualized. We want no rotation, which I misspelled there. The humeral epicondyle should still be seen in profile, much like a regular AP. We want optimal brightness and contrast, and the reason for that is when the arm is in that position, it tends to superimpose upon itself a little bit. So we're going to raise our techniques up a little bit to compensate for some of the whiteness that's going to occur on that x-ray. That's why it's some optimal brightness and contrast. That way we can get as close to a visualization of a true AP as possible, even though we're having to position this patient in a different way. And of course, no motion. No motion on those x-rays. And then when we talk about the forearm parallel, look at the difference here. If I flip between the two, humerus parallel, we got a lot of that humerus visualized, versus forearm parallel, what's visualized? All that forearm. Because that's the part that's parallel on the film this time. So for this one, we want the proximal radius and ulna. They're going to be best visualized. Same thing, no rotation. And we want the radial head and neck only slightly superimposed by the ulna. That's the evaluation criteria for the forearm parallel partial flexion. You see a lot of that forearm on that x-ray. Okay, guys, we will stop right here today on the oblique projections. We don't have much further to go for this chapter. So we will wrap it up on Wednesday, and we'll do a review as well, so you know what kind of questions to expect for the image review on Friday and the chapter exam on Monday. Are there any questions about the material today? Okay. Well, keep a lookout on your emails, guys. I plan to get you some more practice images sent out tomorrow. So look to your emails. There'll be some more anatomy practice for you guys. I'll send that out as early as possible tomorrow. I'll also send the PowerPoint as well to you guys by the end of the day. If there are no more questions, you are dismissed. Enjoy your evening. Good luck at clinic tomorrow, and I will see you all on Wednesday.